Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you for attending our presentation. Actually, today we will talk about a recent and a new activity that will take place in few days in our hospital or in our center. And we've been waiting for that since a long time. There is a lot of trials that has been done in the past, but was not very successful or was not, didn't come to life or didn't come to light. And I will start by mentioning or by describing the address of our presentation, which is Recovery Concepts and Psychosocial Rehabilitation of Psychiatric Patients, Family and Community. And why recovery? Because this is the main aim of our rehabilitation program, which will have inside of it a daycare center, a community service, and a hotline. This triad will all unite in the service of our patients just after moments or maybe hours of their discharge from our units or from our hospital. We all know that the mental health team is the team responsible for rehabilitation of psychiatric patients. But what do they aim to? What is their focus? They focus on two main things. Number one, to maximize the abilities of our patient. Our patient didn't lose all his abilities. ما فقدش كل ما يمتلك من معرفة أو كل ما يمتلك من ملكات معرفية. He didn't lose it all. We want to maximize the abilities and to reduce the disabilities. This is our aim. And during this aim, we found that psychosocial rehabilitation term has been abused a lot. A lot of management and treatment has been named psychosocial rehabilitation, even in psychopharmacology. So to correct some of the use of the psychosocial rehabilitation, at the start, we will say that psychosocial rehabilitation is not a mode of treatment, or it is not a psychiatric treatment. On the contrary, the psychiatric treatment focus on symptom alleviation and stress alleviation, symptom reduction and stress reduction. And this has nothing to do with the return of our patient to the community and the return of our patient to his usual life. ملوش دعوة بأن العيان هيرجع بني آدم عامل وأكتف ومنتج تاني في المجتمع. هنريديوس السيمتومز وده موجود من أيام الخمسينات with the discovery of chlorpromazine. Okay? بس السيمتومز والستريس بتاعها sometimes the family is the one needing this treatment, but the patient needs is to return to life, active, functional, having a job, having a good social support or good social surroundings and a good social activity. Okay. How did we go through community mental health? Community mental health passed through a lot of eras through reform movement. Reform movements, which means slow movements and slow change from one era to another, not a revolutionary movement. It didn't come suddenly and they said we need to make hospitals. Not suddenly, they said we need to make community service. It started by moral treatment in the 17th century and the 18th century, where the mental patients were not looked at as bewitched or as magicians or as any of the possessed by bad spirits or any kind of this. They started to look at them as patients or as people suffering or as victims of a mental illness. But they were not having any place to be treated in at that time. They were only looked at this way. And it changed later on to putting them into asylums and to putting them into places where they are only put away from the community so that they are not dangerous to the community and the community is not dangerous to them. Then it came the mental hygiene era, which is after 1910 or during the 1910 till the World War I, where this is the era where they were very caring about spreading the mental health hygiene through cinemas, through movies, through newspapers, through books. A lot of books were written at that time about stories of mental patients and how they did get the disease and how they were suffering from it and how they were alleviated and treated. This is the era. Then the community mental health, which is the era where the deinstitutionalization happened. At the start of this era, they started taking patients out of the institutes. And this came after a lot of isha'at, inside the mental hospitals. There is abuse, sexual and non-sexual. They are treated badly. They are put inside these hospitals in overcrowding. They sleep on the floor. They are naked. They are not looked after. So people said, why not treating these patients outside? But what happened at this time, that they took them out of the institutes and they were not put in any other programs. There was no community psychiatric community service centers. ما كانش في وقتها centers. So they were in the streets. They started to be abused again in the streets. And in the end, they started thinking about the community services inside the hospitals that can take and reach the patients outside and can see the patients not as an inpatient or as a sleepover patients, but to be part of their day at the home where they live with their families, and the other part, which is during the morning in the hospital, to pass through programs and to pass through rehabilitation programs that is needed for them. So if we, what do we need from our daycare center? We thought about the problem of stagnation in the wards of psychiatry, acute or non-acute, and how can we deal with this? First of all, we thought about making, Dr. Abdul Mohsen thought about making a committee for the revision and for the review of the capacity of the patient and the review of the patient's ability to take a decision, and if really he is needed to be inside the hospital or not. What if we said he is not to be inside the hospital but also not to be outside? Where can we put this patient? Where will we put this patient? So it's the daycare, the only place that can handle this conflict. The daycare can take the patient who are not eligible for hospitalization. He doesn't need to be a hospital. But at the same time, he cannot be taken care of outside. He needs still a medical attention, or let's say a professional attention. Because later on I will discuss the problem of the daycare, that it is not a must or a mandatory to have the psychiatric doctor working in this field. He has to supervise, but not to be the active and the only active one. Of course, we found a problem in discharging patients, or the studies found a problem in discharging patients out of the long institutionalization, because they became, during their stay in the hospital, they became highly institutionalized. They don't feel safe except inside the safety walls of the hospitals. And they start to be begging to return back to the community they were in inside the hospital. The second thing, that families doesn't want the patient in their residence. They don't want to take care of the patient, and they cannot take care of the patient. This is the two things that we found as a problem. Therefore, we had some provision of doing this program of the community program, which will constitute, as I mentioned before, of a daycare center, of a community outreach service, and of a hotline in the daycare center. The daycare center is mean or is caring, first of all, for the biopsychosocial spiritual rehabilitation of the patient. And in this, we are trying to tailor for each patient a program which will help him to function and to return back to the community easily. Each patient has a certain disorder with a certain different, completely social background, with a certain different abilities, and we have to tailor our management for this patient solitary or uniquely. And among the therapeutic approaches that we will do inside the daycare will be the counseling sessions, will be the psychosocial skill training. Also, we will have to do the motivational enhancement, modeling or role play, and all this serves in letting the patient taking responsibility back of himself and of others. Of course, we started this modeling and the role play in our rehabilitation unit in a very narrow scale, and was aiming to make the patient to be put inside a situation which is the role of his role is the one responsible to deal, for example, with a bank account. How can he open a bank account? How can he take money from the bank? How can he use any of the services around? And he take this, and we are helping him in directing his movements and in directing his behavior until he grasps this and starts to be part of him. Relapse prevention and leisure skills. The personnel inside this daycare will be a psychiatrist who is responsible, a psychiatrist and a physician who will be responsible for emergencies of the that can happen to the patient or to any change in his behavior that cannot be controlled by the team there. A nursing staff, which will be, as we did sit the head of the department and myself with the nursing staff, and they promised of giving us about 3 in the morning and maybe 3 in the afternoon to be taking care of the patient during his stay in the daycare. A psychologist, and more than one psychologist, because they are the backbone of our structure, and they will be the one performing all the therapies, all the different individual and group therapies inside this facility. Okay, a social worker who will be responsible, mainly the one we are asking for will be responsible for OT and occupational therapy, and also for the leisure and for the art therapy and for the music therapy. He will be handling these things. And the head of the unit, the head of the rehabilitation unit, will be the one responsible for the daycare center. They will have a record that is very specific to this daycare center. It doesn't have to do anything with the KCMH files. These files will be kept inside the daycare. They will be registered inside the daycare, and they will take care mainly of the number of admissions, the first presentation of our patient, and the medical comorbidities and previous admissions, of course, and his last medication. First of all, the physician in charge or the psychiatrist in charge, in the day the request came for the daycare from the inpatient or from the outpatient, he will see the request and will start applying the exclusion and the inclusion criteria that will be discussed later, and will start see if this patient is eligible for joining the program or not. Not all the patients discharged from the units will be eligible for the daycare program, and we will see why. The inclusion criteria will be relatively age-related, from 18 to 65, and it has to be a stable patient. I cannot take an acute or agitated or aggressive or any form of patients that can be disruptive to the program. And of course, the patient requires a long-term rehabilitation. Also, I need the willingness and the motivation of the patient and of his family, which will give us a support and a push forward for initiating this program and going on with it, as it is a part helping them very much. Sooner or later, the patient had to be discharged and to be back home. So when they have to understand what we are doing, I think the willingness and the motivation of these patients will be of the patient's family. There will be exclusion criteria as shown now. Of course, again, age, and if the patient has any tendency to be aggressive towards himself or towards others, any acute psychiatric symptoms, depressive, suicide, acute depression, suicide, hallucination, delusions in psychosis, or acute manic episode. Any acute stage we cannot accept, of course. Handicapped patients, primary diagnosis of substance abuse, primary diagnosis of mental retardation, handicapped, physical handicapped, I mean, because we will not be able, at least in the start of our service, to deal with this disability, as we are very well meant with psychosocial disability. We cannot deal with the physical disability. And patient with active criminal charges. The schedule of attendance will be flexible. We have a schedule of everyday attendance or every other day attendance, which can be 3 days a week and once a week. At the start of the program, we will have to deal with the patient daily. Sure, we will have to transfer him to the other schedules of every other day or once weekly, but this will take some time. But at the start, mainly we will have to deal daily with our patients. And the activities will start in the morning, as we have settled in our meetings, at 9 o'clock in the morning, and it will stay till 7 p.m. in the afternoon, which is quite a period that can cover the medication, all the medication given to the patient, and can cover his meals even. يعني بمعنى أصح إنه هو مش هيرجع البيت doing anything more than sitting with the family and maybe sleeping at this time. How can we do this? Dr. Abdul Mohsen have agreed of making this patient as an inpatient. We can deal with them as an inpatient facility. So we will take their drugs here from the pharmacy, a meal will be given to them, and they will stay as an inpatient till 7 o'clock. When they leave at 7, it's as if they are having a leave, a usual leave like we do with other patients who stays for long stay, okay? After that, there will be some activities, as I did mention before, in the form of individual psychotherapy, group psychotherapy, social skill training, any other counseling, family education, until the lunchtime, and then the lunchtime will be served. And afterwards, they will lunchtime will take about 2 hours or 1.5 hours. Maybe that will be during the prayer time, if there will be praying in the daycare, or they will go to the mosque. And after that, they will go back again to the program in the afternoon. And we did agree with the head of the psychological department that people working in the afternoon or having the clinic in the afternoon that can be serving us for 2 hours or more as doing their psychological therapies and for the patient in the afternoon. Here is another example of our group activities, psychotherapeutic sessions, educational sessions, social skill training, and also there will be a leisure activities or recreational activities. Indoor, there will be fun days, wellness program, recreational programs, or outdoors picnics to the cinemas, to the clubs, or to any other facility that we can prepare and organize with. There will be a social activity and regular family meetings. Of course, the program will deal mildly with medical problems of the patient. So the treatment, we will give the treatment and we'll follow up the treatment in order to alleviate symptoms and distress. Also, there will be a crisis intervention. If any problem that happened to the patient acutely, we can deal with it, we will. And then there will be a case management. There will be someone responsible for each case that will cause the management, that will draw the plan, and that will put in the patient's file what will have to be done for the next 6 months. This plan can be revised every 6 months. It will be put according to the patient's condition at the end. Also, the rehabilitation will be dealing with the patient's skills, developing the patient's skills, as I mentioned before, and this was through the role functioning, also through the modeling. There will be an enrichment of the patient's abilities, engaging the patient in fulfilling and satisfying activities, which will cause self-development and self-assurance. Also, we will teach the patient about his rights in the family and outside the family, and about the law, some of the law that he has to go with and not to break, and that we will tell him about his rights, advocating to uphold one's right, and about equal opportunities that he has to go through. Not because he is a patient, he will be treated less than any other one. Also about basic support, self-help, and wellness. The day center clinic is proposed also, that can be done as a midway between sending the patient out of the daycare center after he's fulfilled the discharge criteria and going back to the general clinic. If we are not sure that he can be going back to the general clinic directly, we can have this clinic that follow up him once or twice every 2 months, and then when we are sure of him sending him back to the general clinic, we will send him at this time. So it will be serving as a weaning period, عملية فطام أو إفطام للمريض, وهو الديكير كله برضو is a weaning period. Here is the discharge criteria. I think we mentioned that the patient being compliant, and we have reached with the patient the point that we can send him back to the community. He is independent, and he starts to be aware of his rights, and he starts to be socially active, and we can see all this in him. We will send him to the community. Any discharge will happen if the patient needs a serious admission to psychiatric hospital, acute admission to the psychiatric hospital, we will discharge him. Any non-attendance or any delinquency in his attitude to the program or inside the program, the patient can be attending the program, but he's not into the program, he's not working in the program, he's not compliant with the program, he's not, this all will let us discharge, because there is a place for other patients that has to be filled. As a disciplinary action, this will be taken. The hotline service will be put into consideration inside the hospital as a part of the telephone of the patient in the daycare. If he had any problem coming or not coming, have any problem with medications inside the hospital, a side effect, we can help him and direct him, not as a way that we can go and outreach him. It's only a consultation by phone, a hotline. I have this problem, okay, you will be coming tomorrow, we will deal with it, or take this or do this, and this will contain the nursing staff, and that can reach a doctor if needed, but mainly it will be through the nursing staff working in the facility. The community case management or the outreach management, this is in the plan of the head of the department. We did not go deep through it, but this is in our plan. We did reach some agreements with outside resources that can help us in ان احنا نوفر سيارات توصل الاطباء والهيئه التمريضيه الى الاماكن بتاعه المرضى، بس هتحتاج برضو بلان، وهتحتاج ان احنا نعرف الكالتشر هتتقبل ازاي our idea, because I think before كان في trials لهذا الموضوع، وكانوا بيقابلوا برفض لدخول البيت وبرفض للمعاونة وإعطاء الميديكيشن inside the house، أو يمكن رفض لأن الشخص ده جاي كطبيب لمريض عقلي، فبالتالي هم مخبيين أن هذا الشيء موجود. فإحنا هنقدر through this cultural studies اللي احنا نشوفها ونشوف البلانز اللي ممكن تحصل، ان احنا نبدأها ان شاء الله في القريب العاجل. So the outreach teams من اهم الحاجات اللي فيه انه هو focusing on very severe mental illness و focusing on one patient، وبالتالي البيشنت دكتور أو السيرفيس دكتور أو السيرفيس patient relationship ratio هتبقى قليلة. يعني inside the hospital he's being taken care of, for example 25 patients taken care of by one nurse, but here inside his house they will outreach him and they will deal with him only himself. So there is a focus on the patient, a low patient staff ratios, and also the frequency of contact may be very frequent, that can be daily or can be weekly, or at least we here did put the plan of twice per week. Also the team can be planned for later on to be intended to deal with crisis. If there is a crisis outside and the patient has to be transferred to a hospital, maybe we can deal with this problem inside the house, inside his house. This is not sure yet. The team will consist of a social worker, a psychologist, a psychiatrist, and a nurse. And at least two has to be available to go to the to be in the outreach. Two, either a psychiatrist and a psychologist and a nurse and a social worker, but at least two has to be there. The service they will give there will be supportive psychotherapy, family therapy, counseling, educational, and long-acting depot injections. Also, there will be a case manager for this case. When we receive this request, which will be either from the outpatient clinic or from the day care or from the hotline, we have to study the case and then to deal with the case manager, the head of the department and the head of the unit manager, to see what we can do to this case. First of all, is it eligible for community care or not? If it is eligible, what will be the plan, the primary plan? And then the case manager will take a phone of the patient and will call them and will prepare what is the best time, where is the best situation, where is the best setting that we can meet the patient, and will take also in consideration the difficulty of the transfer. Yani we will not go to very far places, but at least in the start it will be inside, for example, the city of Kuwait, and later on maybe we will go outside of this. The case manager will take the data and he will prepare for the team the easiest way to go to this place and in the best circumstances, and will take from the team a feedback about the case from the first and the second sessions seen by, to redraw the plan of this patient. Because when we have a request, it doesn't have everything in it. But when the team visits, we will have a bigger and broader picture of the patient's condition, and they will make another plan for the patient. Afterwards, the patient will be seen in a basis at least of twice weekly, and for a period of not less than 6 months, till we reach a point where we find that even our presence is not needed by the patient. And we can only phone the patient to make sure he is doing the program okay and everything for about 2 months, and then we are able to discharge the patient to return back to just usual follow-up in the clinic, maybe for the medication if needed or for anything if not. I don't want to make it long lecture. Thank you very much for attending, and I think the head of the psychology department has a lot to say because they are the backbone, as I said. She will be with us.
Thank you so much, Dr. Abuzaid, for this great presentation.